So, last week we talked about what? Who was here? Anybody remember? We talked about modes. You met Mr. AC and Lazy SIMV and Kid Pressure Support. And if you missed it, let me know and I'll give you the YouTube link. So this week we're going to review some of that as well, talk about something else. So you guys come to work in the morning and you've got patient KM. He's post-op from a BKA, was hypotensive after surgery, so we left him intubated and brought him to ICU. And he was started on some inotropes overnight on the vent. He had increased oxygen requirements. He's now satting 88%. The ventilator is alarming, airway pressure limited. You request a chest x-ray and it looks like this. And your vent screen looks like this. Any guesses what's wrong with your patient? You just chopped off his leg. His lungs should be fine, right? All right, diffuse bilateral infiltrates. It's like you read those words out of a textbook. What are you thinking is wrong with this guy? ARDS. And you are correct. Okay, so ARDS stands for Acute Respiratory Distress Syndrome. And there's two different diagnoses that people look at. The Ards network is the older one, and it talks about a PaO2 to FiO2 ratio of less than 300. So if this guy was on an FiO2 of 0.9 or 90%, and his PO2 was 70, what would be his PF ratio? PO2 of 70, FiO2 of 0.9. What does that make his PF ratio? Anybody got a calculator? Oscar's going. 77. Is that less than 300? Yes. So we are meeting the Ards network criteria number 1. Bilateral diffuse infiltrates that sort of look like pulmonary edema. Did our x-ray look like that? And then this is kind of no evidence of left atrial hypertension. They used to talk about doing a pulmonary capillary wedge pressure, which I've never done in my life. So you have to float a Swan-Ganz catheter in there. But what you're doing is you're ruling out cardiac, okay? It looks like it's cardiac, but it's not cardiac. Sawa? So you can, do a quick echo, look at the heart, look at what else is going on. So that's the Ards net criteria. The Berlin diagnosis is similar, but it's a little bit more precise. It specifies onset within 1 week of known insult or new or worsening respiratory symptoms, right? So we have weird x-rays out in outpatient. Agreed? We have patients who may have had an x-ray that looks like this, and they felt the same for the last 8 months, and they are not oxygenating well, but they haven't changed in 8 months. That is not ARDS, okay? ARDS stands for acute respiratory distress syndrome. Acute, right? It's got to be soon. Again, the x-ray, not explained by something else. Respiratory failure, not explained by a bad heart. So it's very similar, but then they break it into mild, moderate, and severe, including PEEP. So if your PF ratio is 200 to 300 with a PEEP of 5, 100 to 200 would be moderate, and severe would be less than 100. So if this guy's on a vent, would he be mild, moderate, or severe ARDS? Severe, based on the math we just did, okay? I am not going to spend the next hour talking about the different phases of ARDS and the transudative phase and the exudative phase and the length of time and all those things because we don't have time for that. This is the picture that pops up into my head when someone says explain Ards. And if you Google Ards picture, you get like 5 of these show up on the first Google picture search. So you've got a normal alveoli on this side and a ugly alveoli with ARDS on this side. And so it just explains all the problems. You've got a protein-rich fluid, you've got sloughing of bronchial epithelium, you've got necrotic or something, type 1 cells, you've got red cells, you've got type 2 cells, you've got dead basement membrane, so you can't have good air exchange. So really, your alveoli itself is full of junk, okay? This nice layer of surfactant is full of junk. This membrane, this AC membrane, is thickened. It's full of junk. And your blood vessels are full of junk, all right? Like I said, I'm not going into the pathophysiology. You can read a textbook. But in ARDS, your ability to exchange gas is really difficult, and your ability to inflate the alveoli is really difficult, okay? So makes ventilation and oxygenation really tough. One thing that I think is important to recognize is there are direct and indirect causes of ARDS. So direct are things like pneumonia, aspiration, inhalation injury, pulmonary contusion, direct attack to the lung. Pulmonary vasculitis, drowning. Then you have indirect. Sepsis, major trauma, pancreatitis. Pancreatitis is really good at causing ARDS. It's got a unique talent that way. Burns, so not airway burns, burns to the rest of the body, but just the body's inflammatory process bringing it on. Non-cardiogenic shock, drug overdose, transfusion, trally. We had a patient in Canada when I worked years ago who had surgery on her hand. She went into ARDS. I remember arguing with the ICU doctor overnight because we had only one bed and we had all these maybe patients. And I kept saying, yeah, but there's this one on surgical ward who had the hand operation and she doesn't look good. Well, she had a hand operation. She'll be fine. Guess who we were intubating at the ward at 6 a.m.? So when we talk about direct or indirect, which ones do you think have a higher mortality? Why indirect? You're right. Why? Not keeping time? Not picked in time? Not necessarily not recognized in time. Right. They had one organ problem, and now their lungs are a problem. So you've gone from one organ problem to 2 organ problems or 3 organ, right? So you're adding problems. If they have pneumonia and they get ARDS, they still might be single organ failure, okay? So we gave you this case at the beginning. So how do we ventilate this patient with ARDS? What do we do? The first question is AC versus SIMV with pressure support, okay? And for those of you guys who missed last week and are confused by my pictures, I'm going to introduce you to a few of my friends. All right, we have Mrs. AC. She is strong. She is capable. She is going to help out, okay? So AC is assist control on the ventilator. If a patient is on assist control helps out all the way. If that patient starts to take a breath, the machine supports that patient completely, okay? Compared to SIMV. SIMV, he's kind of lazy. He doesn't really want to do his job completely. So if you tell the machine to give a rate of 10, he says, fine. I'll give the patient 10 breaths a minute. If they want more, they're on their own. They can do it on their own. But little sister pressure support comes along and says, no, I can help. I can help for those extra breaths. And so for those extra breaths beyond your set rate of 10 or 15 or 20, kid pressure support helps out, okay? If this confuses you, you can look at the lecture from last week. If you need the link, I can send it to you. Sawa? So, given what I just told you, you have a patient whose lungs are full of junk. They're not working well. Do we want to support them fully or a little? Should we get them on AC or SIMV? AC, right? Let's help them out. Let's get them all the help they can get. Mortality for ARDS is high. All right, I did not look up the current numbers, but it's not great. So let's help these patients out as much as we can. So first thing when you see ARDS is think, I'm going to go to an AC mode, okay? So then we have the question of volume versus pressure. So both volume and pressure matter. They're both important, okay? More volume will give you more pressure. Too high of either creates barotrauma or volutrauma, okay? So if you're setting a volume control, week 1 we said normal tidal volume is what? Do you guys remember? 6 to 8 mils per kilo. All right, for someone with ARDS, we're going to go lower. We're going to go to 4 to 6 mils per kilo. And we're going to keep our P-plat less than 30. If you have no idea what P-plat means, don't worry, we're going to explain in a minute. If you're setting a pressure, you're going to set your pressure so your max pressure is less than 30, all right? And you're going to target your volume of 4 to 6 mils per kilo, okay? So either volume control or pressure control is okay. It depends what you're more comfortable with. It depends what your senior is more comfortable with. It depends how closely you can watch the patient, okay? If you're on pressure control and your volume is set to 4 mils per kilo, so your patient is 60 kilos, 60 times 4 is, all right, you're set. So if you're, so you're on volume control, okay? Sorry, I may have said something confusing there. If you're on volume control and your volume set to 240, as your patient gets worse, what is going to change? What's going to increase? Their pressure, right? So we need to watch their pressure. But if we're already at 4 mils per kilo, we have to accept that higher pressure, okay? If you're on pressure control and your pressure control is set, so your max pressure is 30 and your volume is 240, what's going to happen if your patient gets worse? Is your pressure going to change? No, it's set. So what's going to change instead? Volume. What's going to happen to your volume? It'll decrease, right? Meaning you won't be ventilating your patient adequately. Okay, so consider if you're at 4 mils per kilo, it's probably safer to go volume control unless you can watch those volumes very closely. So if you're already confused, it's okay. There's something called ArdsNet, and I referenced them earlier. You can Google ArdsNet ventilator card, and this will come up, okay? And so it includes our diagnosis, and then we're going to go through step by step of what they've got on here. So, ventilator setup and adjustment. Okay, step 1, calculated predicted body weight. If you ever are struggling to figure out what weight to use for ventilator settings, here's the formula. Take a tape measure, measure your patients, and it'll give you your predicted body weight in kilos, which is interesting because this is all in inches, but this is what happens when Americans make the rules. So, all right. So 50 plus 2 times 0.3 times the height in inches minus 60. All right, so if someone is 65 inches, you're going to do 2.3 multiplied by 5 plus 50. So 2.3 times 5 is 10 point something, 11. That'll give us a weight of 61 kilos, okay? Then notice it says select any ventilator mode. It doesn't really care. Again, in AC mode, and set the settings to achieve, this is where it gets weird, and I skip this step. It says go to 8 mils per kilo, and then turn it down by 1 mil per kilo at intervals less than 2 hours until 6 mils per kilo. Skip that step. Just go to 6 mils per kilo, okay? there is a little bit of theory behind it, but it's confusing. So start at 6 mils per kilo. And then you're going to adjust your tidal volume and rate to achieve pH and plateau pressure goals below. So let's talk about pressure. We talk about peak pressure, peak inspiratory pressure. So if you look at your pressure waveform on your vent, it normally, on volume control, goes to a point, okay? And that top of the point is your peak pressure. Sawa? That is how much pressure it is getting to get to the lungs. If it's got to squeeze through parts of the lungs and get in there, it's going to be higher pressures, right? Then we can make that air stop and do something called a plateau. And we can see how much pressure it takes to hold the air in there. So you guys all look slightly confused. Let's see if we put this up on our funny ventilator, if we will make more sense. All right, so if we go to volume control, normally don't do a pause, but for this demonstration, I'm putting one in. I'm going to do a tidal volume of, if this guy is 60 kilos, 6 mils per kilo would be 360. Why is it not letting me change? All right, we're going to do 320. So notice here we have a high pressure and our patient is desetting. All right, I don't really care. We're going to ignore the desetting right now. So we have a high pressure and then it kind of comes to a plateau. You see that? So we call this the peak pressure. This would be the plateau. So normally when we don't have a pause, maybe now you'll let me increase. Now you'll let me increase. Okay. So normally you just see the peak. You guys see that? And so right now, what is our peak pressure? 26. All right. And so our goal for our Ards was to keep our plateau pressure less than 30, right? So if my peak is less than 30, do you think my plateau is less than 30? Yes. Your plateau is always going to be less than your peak, okay? So I'm not too worried. But let's say this patient gets sicker. What's going to happen if I make his lungs worse? What is going to change? Our peak pressure is going to increase. Let's see. What's happened to our peak pressure? Has it increased? Right? Because I've made his lungs stiffer. I squeezed his lungs, I wrapped an elastic band around them, right? So now our peak pressure is 33, okay? So to do a plateau, you have to do something called an inspiratory hold, which is not available in this simulation unless I add it in over here. So we're going to do this pause again. So now you can see we have two pressures coming up. You've got our peak and then our plateau. So if you go to our pressures, now we can see that our plateau is how much? 29, exactly. So are we less than 30? Right? So that is our peak and our plateau. Does that make a little bit of sense? So there are things that are going to make your peak pressure worse, and there's things that are going to make your plateau pressure worse. The peak pressure is while the air is going through the lungs. First, it's always going to be higher because that air is moving. Moving air is turbulent and is going to create more pressure, okay? The other thing is anything that creates resistance to flow is going to make that pressure worse, okay? So I want you guys to picture the patient's endotracheal tube kinked, kidogo, sisana, not completely, but kinked a little bit so it's hard for the air to get in, okay? What's going to happen to your peak pressure? It's going to increase, right? What about your plateau pressure? Is it going to change? No, the lungs themselves are fine, okay? So by looking at your peak pressure and your plateau pressure, you can help determine if your pressure is high because of a lung problem or an airway problem. So what's some other examples of airway problems? One is a kinked tube. What else? A blocked tube. What else? Stenosis, right? What if the patient has a really bad lymphoma that's narrowing the airway below the tube? That will definitely cause. What else? Secretions in the airway, right? Not necessarily even in the tube, but secretions in the lungs. What else? Asthma. All right? So all of those things are going to cause higher peak pressures, but normal plateau. What kind of things are going to increase your plateau pressure? ARDS, like we're talking about. What else? COPD doesn't, actually. COPD lungs just turn into like big floppy bags. So it doesn't change the pressure. Interstitial lung diseases, yes. Your pulmonary fibrosis. What else? Pneumonia, okay? Anything that makes the lungs less able to take air. So even something like a pleural effusion or a pneumothorax, the lung itself is fine, but it has less room to expand, okay? So we always want to see if our problem is, so let's ask this question differently. If I have my kinked tube, my tube that's partially kinked, and my peak pressure is 50, and my plateau pressure is 25, am I damaging those lungs? No. The pressure in the tube is super high, but my lungs aren't getting that pressure. So it's plateau pressure that we want to keep below 30, okay? A lazy way of saying that is peak below 35, because if my peak is 35 or less, my plateau is going to be less than 30, or close enough to. But it's good to know what that is. Sawa? Does that make sense? So anytime you're taking care of a patient and their peak pressure is high, what should you do? How can you impress your consultant? You can check a plateau. So for our machines, you've got the 4 knobs on the bottom, and then there's 3 buttons, maybe 4, beside the knobs, okay? One of them is Inspiratory Hold. So if you hold that down, you'll see your peak and then your plateau. If you want to see the number, because you want to see the number, hit additional values on the bottom right corner of the screen, and it'll give you a line for it, and it'll tell you what it is, okay? So when you're looking at the vents tomorrow, you can do that. So when you have reduced compliance, stiff lungs, you're going to have a higher P-plat. It's harder for the lung to inflate. If you have increased resistance, you're going to have increased peak pressure. So PIP is peak inspiratory pressure. I like to call it peak because in Kenya we would pronounce this peep. All right. So one of the modes we have not talked about yet is PRVC mode. Okay. This stands for pressure regulated volume control. Some machines call it APV-CMV, some call it VC+, some call it autoflow. So how this works is, let's look at our ventilator here. Stand back ventilator. Let's go to pressure control, okay? All right, so we're ventilating this patient on pressure control now. Sawa? You have a consultant, and he says, I want a tidal volume of 450. What is our tidal volume right now? 311. So how do we get up to 450? Actually, let's not make it 450. We won't get there. Let's make it 360. 360. You want a tidal volume of 360. How do we get there? So what are we going to do? Increase the pressure? Yes? All right, so we're at 15 now. Let's go up to 20. All right? We'll wait. We're going to increase our SATs, or our FO2, because for some reason we're desatting. All right, oops, sorry. So, are we at 360 yet? What do we got to do? How do I get to 360? Almost there. Am I there? So how do I get there? I need to increase the pressure some more, right? Oh, are we getting there? Yes? Okay, then the nurse comes and gives the patient a good suction. Now what do we do? We're too high. What do we do? Decrease the pressure. All right, we want 360, right? Then, oh, now we're way too high. What do we gotta do? Go way down, right? And then the patient throws another mucus plug. What happens to their volume? It goes down. So what are we gonna do? Who thinks this full-time job is really stupid? Yes? All we are doing is adjusting the pressure breath by breath, right? We see what the last volume was, and we're going to increase the pressure up or down to try get the volume, right? And so we could go to our consultant, why not go to volume control, right? If you're so picky, and your consultant says, volume, I want to be able to keep that volume of 360, but pressure control is more comfortable for the patient. They get a decelerating flow waveform, and they're more comfortable. So keep it at 360. All right, are you annoyed? So you understand his logic, but you'd rather be in the OR or delivering a baby or resuscitating a baby or doing anything else but standing here, turning the pressure up and down. Can a computer do what you're doing? Can a computer take information and apply a change? That is what APRV is, or on this machine, APV-CMV. You set a volume, so we said 360, right? And the machine is going to give that decelerating flow waveform that your consultant wants, okay? The patient can get as much flow as they want, but the machine now is upping the pressure breath by breath to help the patient, okay? Does that make sense? So PRVC can be a really helpful mode because the patient might be more comfortable, okay? They can get more flow. However, if you have a patient who's breathing really erratically, do you think this mode's going to be happy? Maybe they've had CPR and they've had CPR and now they're gasping, right? They don't breathe for a while and then all of a sudden they go and take like a 3-liter breath. So if they just took a 3-liter breath, how much pressure is the machine going to give them next time? Nothing. And then they're going to get 50 mils and the machine's going to go, oh, now I got to give more. Okay, let me give 10, and then they start all over, right? So if a patient has an erratic breathing pattern, they don't like this mode, okay? What if you have a patient who's, maybe they're in DKA or some other metabolic acidosis and they're sucking back? Is the machine going to give them any pressure? No. You're going to see your pressure here being 5 or 0. So is your machine helping them anymore? No. So with those two types of patients, you probably don't want to use PRVC. Otherwise, for ARDS patients, it's a great mode because you can give them a little bit more flow and still regulate your volume, okay? So there is AC PRVC mode and SIMV PRVC mode. Sawa? Does that make sense? Okay, so the next chart on here, on this ArdsNet card, talks about PEEP. What is PEEP? What does PEEP stand for? Positive and expiratory pressure. How many of you guys have seen my favorite movie in the whole world? You guys seen this one? I love this movie. Favorite movie. It better work. Oh, the voice is boring. Okay, so now we're on no PEEP. So notice as the lung inflates, there's these areas here that are not participating in gas exchange. You see that? Right? Now they've applied some PEEP. What do you see happening to those areas? They're being recruited. They're opening up, right? We're almost there, almost all there. Wait for it. One more. Oh, right? So look how beautiful that lung looks, right? This lung is being used efficiently. All the areas are participating in gas exchange compared to over here. Look how sad and depressed that lung is, right? You have all these areas. Is any oxygen and CO2 exchange happening here? No. Those alveoli are useless, right? So PEEP, when they applied PEEP is when this opened up. What is interesting is, watch what happens when they take away the PEEP. Wait for it. There it goes, no more PEEP. Look how quickly we go to being a sad, depressed lung, all right? So you disconnected the patient to go to CT and beg them. And now your lung looks like this again, right? So a normal, healthy lung will look like this without PEEP. Is an ARDS a normal, healthy lung? No. So they're going to have parts of the lung that look like this, all right? One of the things of ARDS is you're going to have areas of good gas exchange and areas of really bad gas exchange, okay? But if your patient is hypoxic, we can give more oxygen and allow these parts of the lungs to be used more effectively, these parts of the lungs to do all the work with high amounts of oxygen, right? What happens if you give a patient too much oxygen? Oxygen toxicity, free radicals, all sorts of bad things. So oxygen is not the answer, okay? And we're wasting parts of our lung. Our patient is much happier and healthier if we give them PEEP and give them less oxygen, okay? So they have created these Peep Tables. This is the low PEEP one. This is the more common one. Again, low PEEP. What is the amount of PEEP it gets to? 18 to 24, okay? That's the low PEEP one. The difference between the low PEEP and the high PEEP is how quickly the high PEEP one goes up. So what this means, when I walk into ICU in the morning and I find someone on an FiO2 of 90 and a PEEP of 8, something is wrong, okay? Either that patient shouldn't be on that much FiO2 or they should be on more PEEP, okay? If they're on 90%, their lungs are bad enough, unless it's a PE. Does PEEP help with a PE? No, your lungs are fine, right? It's just the blood moving through them isn't moving. So, but if it's a patient with lung issues, if you're on a high FiO2, you need to consider using more PEEP. So let's say we have this scenario. Your patient's FiO2 is 90, and their PEEP is only 8. Should we immediately increase it to 14? No, we can probably go to 10 or 12, right? And we should be able to get our FiO2 down, probably to 70, right? And kind of meet in the middle, okay? What is a side effect of PEEP? What can happen when you give PEEP? Barotrauma is actually not a problem with PEEP, and I will explain why in a minute. I'll show you. You actually prevent injury with PEEP because when you look at the lung here trying to be inflated, notice how much pressure it's taking to inflate it. It doesn't tell you pressure. but it's taking a lot. We're inflating during inhalation, and then we're collapsing. And then we're inflating, and then we're collapsing. And so we're taking this lung, and we're pulling it apart. We call that shearing forces, okay? So you're actually causing damage by letting the lung collapse. Once the lung is inflated, it doesn't need as much pressure to inflate every time. So barotrauma is not actually a problem with PEEP. Right, so you have increased intrathoracic pressures, which does what to your venous return? Reduces, which does what to your blood pressure? Decreases, okay? So as you're increasing your PEEP, keep an eye on your blood pressure, okay? If your blood pressure drops, what do? Do we take it back and then let your patient be hypoxic? You're playing a game, right? Your patient probably needs PEEP, but they also might need some pressors, okay? It's not wrong on high PEEP to give them a little bit more inotrope or a fluid bolus to do it. When you really get into trouble is if you have pulmonary edema and then you're giving more PEEP and then you decide to dump more fluid in. Don't play that game. Try to avoid that game, all right? Sometimes they are third spacing and you're in trouble and you just have to, but that's when you get into trouble. Okay, so let's talk a little bit about blood gases. Did I not copy this one? Did I miss this one? All right. So let's look at the vent together, and I will give you a blood gas, and we'll discuss it that way. Yes. No, you Google it. If you Google ArdsNet ventilator card, it's meant to like sit in your pocket. So let me see if I actually have the one that's missing. Okay. So let's look at this ARDS patient again. Let's do a scenario here. Give him his Ards back. So let's say we're starting up ventilation for a patient with ARDS. What mode do you guys want to do? AC. Then what? Doo, 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 doo. The nurses put some setting in. Your patient's already desetting. What mode do you guys want? PRVC? Okay, that's this one. You don't need to remember that. So we go to PRVC. What tidal volume do you guys want to use? Your patient is 60 kilos. 360, right? We're going to start at 6 mils per kilo. All right, what PEEP do you want? 6, any other votes? 10? Go big or go home? All right, what FiO2 do you want to start with? 70? All right. What rate do you guys want to start with? I got a vote for 12. I got a vote for 15. Any other votes? No 13. Kyle is just trying to annoy me. No odd numbers unless they're multiples of 5. If you want to make me twitch, you guys can have fun with all the vent settings. So, multiples of 2 or multiples of 5? What do you guys vote for? 14? All right. So, our vent is alarming. What is our vent alarming? Pressure limitation. What does that mean? The lungs are not well recruited. All right. The lungs are bricks. The lungs are not doing well, all right? So pressure limitation means, what is our volume set to? How much volume are we getting? Why? The compliance is horrible, but why isn't we are on PRVC. The machine should do what to get more volume in? It should be adjusting the pressure, right? Why isn't it giving more pressure? So what the machines do is our machine in our ICUs, the Servo I, right now we have a high pressure alarm. Okay, the machine knows if we reach that high pressure alarm, we are going to end the breath. Okay, we are done. That pressure should not exceed 40. Okay, but on PRVC, the machine is setting the pressure internally, right? And it says, okay, I'm going to stay away from this number. So some machines stay away by 5 or some machines stay away by 10. This machine in our computer stays away by 10. Our machines stay away by 5, okay? So let's increase this high pressure alarm a little bit. So then so if it's at 45, it should limit it at 35, okay? So, but are we reaching 360? What do we do? So part of the ventilator card, well, let me put this on top. No, says if the pressure is above 30, if your plateau pressure is above 30, you can do what to the tidal volume? What did we say tidal volume should be? 4 to 6. So 60 kilos, what do we go to? 5. We go to 300 mils, right? 60 times 5? 300. Anyway, so now our peak pressure is 35. On PRVC mode, your peak pressure and your plateau pressure are going to be the same. So it's another reason it's good for ARDS is you can be lazy and not have to check your plateau pressure because it's the same. All right? So right now at 5 per kilo, we're at 33, 32. You know what? It's close enough, okay? What else is alarming on this machine? You guys have never seen this alarm before. This is an end-tidal CO2, okay? And so in our life, we have to do a blood gas. So we do a blood gas on this guy. pH of 718, PCO2 of 68, and a bicarb of 20, and a PO2 of 59. What's wrong with our patient? What's our interpretation of the gas? Are we acidotic or alkalotic? All right, what's the cause of the acidosis? Is the bicarb helping or hurting at 20? It's not helping. What's normal bicarb? So your bicarb is actually hurting, right? This guy is also septic, right? He had a BKA because he had a necrotic leg from diabetes that hasn't been managed, and you know, all of those problems that we like to see. And his lactate is 5, right? He's a mess. So he's a mixed acidosis, but mainly respiratory. All right, this one's our fault. We have to do something. So what do we do? But shouldn't 14 be an adequate rate for a patient? It should. Why is it not for this guy? There's 2 reasons. He needs to get off CO2, right? He needs to breathe more to get off his CO2. Why? Why is he needing to breathe more often than you guys sitting here breathing at a rate of 12? What's different about him? There's 2 things going on different. 1, he's got ARDS. Picture that picture, right? His lungs are full of junk. Second reason, what is his tidal volume? It's low, so if we're reducing someone's tidal volume, how do we compensate? Increasing the rate. So we should have known this was coming. We should have gotten ahead of this, right? Right? We've talked about minute volume before, the amount of air they breathe in a minute. His is low because we've reduced his tidal volume. So anytime you're doing low tidal volume ventilation, we have to compensate by increasing his rate. So what should we increase his rate to? I don't like 16. 16's like nothing. Let's give me a better number. 20? Probably 24, 25. All right. We are set at a volume of 300, right? 300 times 25 gives us a minute volume of 7.8 or 7.5. Normal is 5 to 8, right? We probably need at least normal to maintain his CO2s because his lungs are full of junk, okay? So I would probably increase his rate to 25. All right. Interesting. In doing this, I don't like what the machine's doing. I'm going to make it stop doing it. So what was our PO2 on the gas? It was like 59, I think, right? So what else do we need to do? So our FiO2 is 70. Our sats are 90. Do we increase the FiO2? What is our PEEP? Our PEEP is 10. What do we do? I would probably increase our PEEP. Just to show you, it's doing something I don't want it to do with the increased rate. So just for showing you guys, we're going to drop the rate back so it stops alarming. So our PEEP, we've increased to 12. What do we need to watch as we increase our PEEP? Your blood pressure, right? So we do a blood pressure. He's on norepi. It is 95 on 50. Are you okay? I am. Yeah, that's fine. It's not great, but we're broken on multiple sides. So what else changed as we increased the PEEP is we saw our peak pressure go up a little bit, okay? The reason is as you increase your baseline pressure, the delta, the pressure between them, often will stay the same, okay? So we were at a PEEP of 10, and we were going to 32, so the delta was 22, right? Now we've gone up to 12, and that delta is probably still going to be 22, giving us 34, which is close to 36, all right? However, as we recruit more lung areas, what's going to happen to your pressure? Your pressures may come down. And this is why PEEP is actually protective, is if you're opening up the lungs, if you're ventilating an open lung, you shouldn't be using high pressures for too long, okay? So, but now our pressure is 36. So what should we do? Do we need to go down to 4 mils per kilo? Yeah. So 60 times 4. All right, at this point, if you weren't too sure about the weight, you might want to double check, okay? Because if you're guessing 60 and someone else is guessing 70, that end starts to become a bigger percentage of their volume. Does that make sense? Right? And our pressure came down. As we reduce the volume, what do we have to do as well? Increase the rate. So we're going to hypothetically increase this from 24 to 30, okay? Ignore the fact that I made it 15 because the machine was doing funny things. How high can I go on the rate? Can I, if he's acidotic, can I keep going higher and higher and higher on the rate? What's wrong with that if I keep going higher and higher on the rate? Breath stacking, okay? Breath stacking, also called auto PEEP, okay? Also called air trapping. What can happen is, this is our flow waveform, okay? As we increase our rate, it becomes the amount of time we have to breathe in stays the same, but the amount of time the patient has to exhale gets shorter, okay? And so if they can't exhale all the way, you're going to have an increase in pressure because you're giving air to a lung that's already full, okay? So the trick to do is to watch your flow waveform. We can't see it on the board because the simulation is not perfect, but the flow waveform is the purple, right? So when you're breathing in, it's positive. This marker works. Not at all. As the patient exhales, you want them to exhale all the way back to the baseline, okay? And then the next breath's going to start, okay? What if as a person is exhaling, they haven't reached baseline yet, and we start a breath? You're going to see it cut off and go straight up. Does that make sense? So you need to watch for that air trapping on the expiratory limb here to see, is it going all the way back to baseline, or are we going halfway and then starting the next breath? So you can increase your rate until air trapping starts to happen. In a patient with ARDS, that happens at a rate of about 30. If it's a patient with really bad COPD or asthma, that might happen at 15, okay? Because asthmatics and COPD patients take a long time to breathe out. Sawa? Swali? Does this sort of make sense? Yes. So there's nothing wrong with increasing the FiO2 when your patient is acutely desatting, okay? Right now, our sats are 91. So in ARDS, in COVID patients, in patients with really bad lungs, we have moved the bar and said sats greater than 88 are okay. It's safer for the patient in the long run to let them sit 89, 90 than to be at high FiO2s for a long period of time. So our goal should not be sats of 95 to 100 on all of our patients, okay? It actually really annoys me when I walk into ICU and everyone's satting 100 and everyone's FiO2 is 60, 70, 80, 90. No, they don't need it, right? We should keep patients on the minimal oxygen they need to keep their sats 90, 88, 89, right? I don't want them satting 84, 85, but they should be a little better. So, and the question you need to be asking every time you increase the FiO2 is why? Why does this patient need FiO2? Okay? So this morning on medicine, as we were rounding, my patient was desatting. So we turned him up to 100%, and we said, why? And that's fine to do as you're thinking, right? You know what? This patient has neuromuscular disorder. He doesn't have a great cough. We suctioned him, and we pulled out all these lovely boogers. And his sats came back up to 100, and I could take my FiO2 right back to where it was before. He was full of secretions. Literally, he just had a pile sitting at the base of his tube. It was lovely. I have a weird opinion of lovely, I know. So it's just good to get that stuff out. Or are they desatting because I'm under-peeping them? I need to recruit more. then I need to consider more PEEP. Are they desatting because my blood pressure is too low? If you have a patient who's hypotensive, they may be hypoxic because we're not perfusing the lungs adequately, or we're not perfusing the finger adequately to check the SpO2. So if you call me at 2 in the morning and say, hey, my patient's hypoxic and hypotensive, I might tell you to fix the hypotension before we can fix the hypoxia. And also my solution to fix the hypoxia is PEEP, which is going to make the hypotension worse, right? So if you're having blood pressure issues and oxygenation issues, you have to work on fixing them both. It might mean putting them on 100% while you quickly get the blood pressure issues under control, hopefully. And then saying, I don't want to leave this patient. Even then you might say, oh good, my sats are 93, my blood pressure is 100 systolic, now I can go home. No, at this point you should say I should probably increase my PEEP. For 2 reasons. If you leave the patient on a FiO2 of 100, what are the nurses going to do next time the patient desats? Call you. If you leave them on an FiO2 of 70, what are they going to do next time the patient desats? Increase the oxygen. Which one lets you finish your case or finish your notes or sleep? So walking away from a patient who's satting or FiO2 is 100 doesn't leave you in a good position to go sleep. So you want to optimize them before you go. Increase their PEEP. Does PEEP improve sats slowly or quickly? Slowly. It's going to take, you might see an acute jump, but it's going to take time. So I've done it before where they're on an FiO2 of 100, their sats are 80. I increase their PEEP from 6 to 12, and I watch it come from 80 to 83, and I sit there some more, and we get an x-ray, and I sit there some more, and then I see 85, and I say, good. I tell the nurses, call me if it goes below 85, and I go and do other things. And then I come back 2 hours later, and they're satting 95 because they've popped them open. We moved to that lung. That's working well. Sawa? Swali ingine? Clear as mud? Hakuna swali? All right, I think we will end there.